This is a 5-minute evidence-based guide to breast cancer nodal target delineation based on 275 separate local regional recurrences mapped from 161 patients who had detailed imaging at the time of their local regional recurrence. We start at the bottom of the cricoid cartilage, and the highest density of SCV, meaning supraclavicular recurrences, are in the medial SCV, which is behind the sternocleidomastoid muscle in front of the scalenes extending to the medial border of the carotid artery. This is the same as level 4 in head and neck anatomy. We also cover what we call the lateral and posterior SCV areas, bounded by the scalene muscles, levator scapulae, and trapezius muscle. The posterior field is simply posterior to the patient's midline. If we look at the patterns of recurrence at this level, the red dots represent a recurrence after radiation therapy, and you can see both would be covered by this volume. Now moving down 3 slices for brevity, we continue to cover the medial, lateral, and posterior SCV. 14% of supraclavicular recurrences were in the posterior SCV and were not associated with any particular clinical characteristics at baseline, so we would recommend routine inclusion of this area in the SCV field. The remainder of recurrences are roughly equally split between the medial and lateral SCV. Red dots represent a recurrence after radiation therapy, and yellow dots represent a recurrence after surgery without radiation. Although there were a number of recurrences between the carotid and jugular, as well as posterior to the carotid, there were no recurrences medial to the carotid artery, so you can stop the contours on the medial edge of the carotid and spare some dose to the thyroid and esophagus. Moving down 3 more slices, the lateral and posterior supraclavicular areas now include the entire fat space surrounding the clavicle. At this level, this includes the space bounded by the scalene muscles, chest wall, trapezius, and pectoralis major muscles. Notice no attempt is made to spare the clavicle since the immediate periclavicular area is a common site of recurrence. Moving down 3 more slices, continue to cover the medial SCV all the way to the posterior sternocleidomastoid, including the strap muscles such as the sternothyroid here, because some recurrences do occur anterior to the strap muscles. At this level, you can see the subclavian artery after it branches from the brachiocephalic on the right or from the aorta on the patient's left. Although it's reasonable to include this in the target volume, we did not see recurrences posterior to the intrathoracic subclavian vessels. Remember to be very tight on the chest wall, as this is a common site of recurrence. Now we're 1 slice above the sternal notch, and thus the bottom of the medial supraclavicular field. Here the lateral SCV area, which is simply lateral to the sternocleidomastoid, is more accurately the postclavicular area, which now connects to the axillary levels 3, 2, and 1. Notice axillary level 2 includes the intrapectoral space between pectoralis major and minor. Notice we're well below the level where the axillary vessels cross the medial edge of pectoralis minor, which is where the original arteriogialis would say axillary level 3 ends. However, we would recommend continuing to cover levels 2 and 3 as long as a fat space is visible. Level 1 should go a little beyond the pectoralis and latissimus dorsi muscles, but does not need to routinely go all the way to the skin because we do not see nodal recurrences at the skin in the axilla. Here we're 1 slice below the clavicular head, so you can no longer see the clavicle, and this is where we began to see internal mammary node recurrences. The internal mammary vein dumps into the brachiocephalic vein, so we generally began to contour the IMNs at this level. 6% of the internal mammary recurrences were between the clavicle and first rib, and almost 2/3 of the IMN recurrences were in the first intercostal space, while none were below the third intercostal space. Moving down 3 more slices, we continue to cover axillary level 2 as long as a distinct fat space exists. Here we cover 5 millimeters around the internal mammary vessels, which is best seen with contrast. Now that we're in the first intercostal space, we cover the internal mammary nodes from the sternum medially to 5 millimeters lateral of the internal mammary vessels. We stop contouring the internal mammary nodes at the top of the junction of the 4th rib on the sternum. These target volumes would cover 98% of the 275 local regional recurrences we were able to map by imaging over a 10-year treatment period. However, remember that these patterns of recurrence may not apply to every patient, and clinical judgment is still required.